right. Well, welcome everyone. Are we just to confirm, are we all set and recording and everyone's in the session?
Everyone should be joining now. Yes, and we are recording.
Excellent. All right. Well, thank you everyone for joining the AHPBA mentorship webinar. This is a brainchild of Dr. Morgan Bonds, who will be joining us shortly as part of her committee and also a collaboration with the DEI committee, for which I'm the chair. And we wanted to provide an opportunity for various members of the AHPBA who have specific focuses in their practice and in their careers to provide mentorship to the larger group of AHPBA members. And so we got a good group here today, and they'll each get about 7 to 10 minutes to do a presentation on, their thing, the thing that really defines their career, and then provide a way for you guys to ask some questions to them for a bit of time, and then get their contact information in hopes that you will stay connected, meet them at the national conference, and provide some element of mentorship. So we'll get started here for the sake of time because there are several people that we want to highlight. We're going to start first with Dr. J. Bart Rose. He is currently at University of Alabama in Birmingham. He did residency at Virginia Mason Medical Center in Seattle, and then fellowship in hepatobiliary surgery at Washington University in St. Louis. He's got an extensive history and experience in scientific research for about the last 15 years or so. Don't want to age you too much, Dr. Rose. And in various elements. Now, I won't go into all the details of that because he's going to give you some of that information here shortly. So thank you, Dr. Rose, for being available to us, and I'll hand it over to you.
I appreciate that. Thanks, Dr. Washington. So I was asked to speak on research and grant writing, and I do have some experience with that. I want to cover today specifically talking about how to select a research project topic if you're kind of new to research or just beginning your career, finding a mentor, writing a successful grant, which I'm still working on. I've had some success and always would appreciate more. And then trying to balance that career in academic research and being a busy surgeon, as well as everything else that happens with the rest of your life, which I think we're all trying to do a little bit better on at all times. So the first thing I want to talk about was just selecting a topic. There's the topic of research is broad, right? I think all of us, just being physicians, are scientists. We're always curious about things. We're trying to answer questions either about our patients or maybe more broadly about a specific scientific topic, disease process. And that could be something, basic science. It could be translational. Maybe it's trials. Maybe it's big data. But, what are your interests? Kind of think about maybe what you do. We're all members of AHPBA, so I'm assuming most of you are interested in the liver, pancreas, and bile ducts. But there may be some niche of that you're interested in. What are the strengths of your institution? So look around and see, what is it potentially that you could study? What kind of questions could you answer where you are that maybe no one else can as well as you? So, when I came to the University of Alabama, one of the things that we can really try to help with and answer some questions that are a little bit easier for us than other places are things centering around disparities research or the ancestral differences between different patient populations that may be contributing to their disease processes. And the University of Alabama has been very successful in this. Who else is in this space, both at your institution and nationally? And you want to look at that kind of from 2 points. One, is this somebody who maybe is a potential mentor for you in the future? Is this someone who you'd be able to collaborate with? And then is this space saturated? Sometimes coming in as a junior scientist, looking at a space where there is a lot of funding and a lot of people working in this space, it can be very hard to break in. And you may make a calculation that, I have this experience, I have these resources available at my institution, and of maybe one or two or three topics I'm interested in, maybe one of them is a little bit less studied, and sometimes going on the road less traveled leads to more interesting places. And then be realistic with yourself. I think, there's a lot of people who say, like, I really want to do hardcore bench science and research. And that can be very challenging. It can be very challenging, especially as a surgeon, and even more challenging as an HPV surgeon. You're going to be competing against people who are full-time PhDs. You're going to be competing against people who are medical doctors who have on and off service time. Maybe they're only working clinically for 1 out of every 6 weeks, and the rest of that time they have dedicated time to be spending in their lab and writing grants. And that's going to be very challenging for you to compete in that space. But if that's something that you love, then that's something worth pursuing. The next is finding a mentor. So I've kind of posted some examples of some of the mentors that have really contributed to my career, both in the research side of things and on the clinical side of things. But I would say, be open-minded. You never know where a mentor is going to come from. It may often not be the first choice. You may be starting out an institution, you may be assigned a mentor. There may be formal mentorship programs where you are. There may not be. Um, but keep an open mind and look for them in any place, and they can be in different fields. In fact, I would encourage that. I've had mentors. The person here on the top left was one of my first mentors back in my neuroscience days, and he is now one of the directors of the NIH in the Institute of Aging. But he's a pathologist, and he studies Alzheimer's disease. The other people, most of these people here, those members of the AHPBA may recognize. Um, Scott Helton, Flavio Roca, Steve Strasberg, Bill Hawkins, and then Herb Chin, my current mentor, and then Stan Crook, who uh, runs a biopharmaceutical company that I used to work for in San Diego. And these were all mentors, both on the science side, with Herb being my current mentor, and then others who inspired me clinically and to answer important clinical questions. The other thing is have many. Don't just have one mentor. It's always good to have many mentors that can complement each other, and help you answer different questions and guide you in different aspects of your career, because it's going to change over time. And I think the most successful people in this field have probably pivoted more than once. You go down one pathway, maybe it's not panning out, maybe something happens you weren't expecting, and you need to be versatile and be able to pivot. And having many mentors and being willing to accept advice from different people can be critical there in a successful pivot. And I think and always be looking to see if this person has your best interests. Avoid those who put themselves first, because that's not really a true mentor. You don't want somebody who's trying to get you to do scut work for them and then claim credit for your work. You really want somebody who's looking to advance your career and making sure that you are successful. And then keep in touch. Mentors will come and go in different capacities, but I think keeping in touch and touching base every now and then is good. They're invested in you for the life of your career, and I think they're very interested in hearing how you do and seeing how successful you are. And sometimes it can be very rewarding to be able to reach back out and then maybe contribute back to them at some point in your career. As far as grant writing goes, so start small. I think as you're writing, it may not be best to come out of the gate swinging for an R01 or a big program project. There is a lot of subtlety and art to grant writing, and every different mechanism may be slightly different. But I think just if you're starting out writing for grants, is start for small society grants. Kind of learn the ropes, learn what people are looking for, and build up. Get lots of help. This is for most of us a completely foreign thing. The structure of grant writing, how to write it so that you can convey your message, is not something that's taught in medical school or in fellowship. And there is definitely an art to it. So there may be programs at your institution. You could take maybe a course through the AAS. You can reach out to mentors, ask for examples from people who have been successful. When I was applying for my K grant, I asked a lot of people who were successful in getting funding for theirs, and if I could, use parts of their grant, the structure of it, because I liked the way it laid things out. And submit a lot. This is totally a numbers game. The more you submit, the more likely you're going to get funded. Sometimes it's going to feel completely arbitrary submitting for these grants. You submit something, study section has very minor problems with it. You're very excited on your resubmission, and you fix all the things, and you get a worse score than you had the first time. And it's demoralizing. You can't take it personally. You just put your head down and you keep going. And get used to failing. I mean, it really is feeling like you're hitting your head against a wall. But the more you submit, the more you take that creative criticism, the better you're going to get, and you will be successful. And then lastly, I just wanted to touch a little bit about on balance. You need to protect your time. So if you're going to be a successful surgeon scientist and trying to do everything, the only way you can do that is by keeping organized and having incredible time management skills. I mean, one of the first thing that Herb Chin sat me down with when I started was working through how to organize my Outlook calendar so that I had excellent time management skills and I was protected to do the things I needed to do. And having that mentor, and especially in a chair or a division director who's committed to your success and is going to not just say you're going to have 75% protected time on paper and then expecting you to make 10,000 RVUs a year, is going to be, very critical to your success. And I think, being a good scientist and being a good surgeon is great. I'm sorry, being a good researcher is great, but being a good surgeon is more important. This is, I think, whether or not you get your next grant, whether or not you get the next paper out, is really secondary or tertiary to being an excellent surgeon. So, especially for what we do, there's a lot of technical skill that's involved in this. I would encourage you to be operating even in those first couple of years with your protected time, and make sure that you keep your skill set up. And it is a tough balance, but I think it's hard to get those initial operative years back after your fellowship if you've lacked confidence and haven't had exposure. And then have fun. I mean, this is an example of my team and I. We're doing a Whipple in this picture here. This is a mentee of mine who got a plenary at the Pancreas AACR symposium. I'm very proud of, and he completed his PhD in my lab, um, and is moving on with his career. And this is our lab out on our lab day. It's a joint lab between myself and Herb Chin and clinical and bench science group, and just having a great time out. We went kayaking on one of the rivers here. My oldest daughter comes with us on that. And then as the others get older, they'll start coming with us too. So enjoy it and remember what's important. And that's all I have. Ready to take any questions if anybody has any.
Thank you so much, Dr. Rose, for that. I will honestly say that the grant applications and applying to many and being used to getting getting rejections, I think it's definitely something that I needed to hear. Certainly, if anyone has any questions, feel free to place those in the chat right now, and we can answer some of those questions before we move on to our second panelist. We will also have some time at the end in order for others to ask questions at that time. But I did, just in case anyone had any burning questions currently, I did want to give that opportunity for people to write those in the chat. In the meantime, I'll ask one quick question myself, Dr. Rose. If there was one thing you could tell someone who was early in their career with an interest in research, whether they're in an academic, hybrid, or community environment, if there was one element that they could walk away from this with, what would be that biggest thing?
Build a team. Do not try to do this all on your own. I think that that is something that many of us are so used to being. We're very competitive. We want to show that, we can do this, that this is something that I can do on my own. You can. If you want to be a successful researcher, this is a team sport. You need to build a big team, find out where your weaknesses are, and then fill them in with an expert in that, because especially on the basic science side, things have become so um, compartmentalized, just like in medicine, that reviewers on grant study sections are going to recognize that, and they're going to say that this person is not an expert in this, and they're going to kill you on the grant. Find expertise, find help, find collaborators, and build a big team.
Excellent. Thank you for that. We do have a question in the chat from Rakesh Ramboli. Sorry if I'm butchering your name. I apologize. Do you, Dr. Rose, have any suggestions for those who are international surgeons to source grants in third world countries? Are there any resources you're familiar with?
Boy, I'm sorry, that's not something I am familiar with. Maybe Dr. Kent may have some ideas in that, because she does some international work. In fact, she's going to be joining us, I believe, from Vietnam tonight. So that's not something I really know. I know that the AHPBA grant is open to international people. We've had people apply for that. It's not a lot of money, but many of the society grants don't limit where you're applying from. Unfortunately, a lot of the larger ones do. So I would encourage you to apply for different society grants.
Absolutely. And
Um,
Dr. Ken, if you have anything to add there, we'll allow that, and then I'll introduce you, and we'll table some of the other questions for the end.
Yes, I agree. I think looking for society grants is likely a good option. And also some of the more international funding agencies, like what Dr. Rose is referring to is the USAID grant. But certainly that's not a grant I wrote. I'm a component of it, but it's a huge programmatic one.
I see there's a question from Dr. Jay Raja about clinical and research interests being the same. They don't have to be. So I'm a mentor for one of our endocrine surgeon faculty who is studying pancreatic adenocarcinoma. So just because that's an interest of hers, but it's not what she does clinically. So I think that the alignment there, it can help, but it is not required.
Awesome, thank you. So we'll move on to our next panelist. This is Dr. Tara Kent. So she's an associate professor of surgery at Harvard Medical School, has extensive experience in the field of medical education. She's currently the program director for the general surgery residency program and has been that since September of 2012. It's about 45 categorical residents and 11 preliminary trainees, so moderately to large size program. She's also been the vice chair of education since 2014 and oversees her departmental education programs, not just for the residents, but also for the students and the fellows. She also serves on the Entrustable Professional Activities, or EPA, which I'm sure a lot of people have heard about, working group, representing the AHPBA on the Fellowship Council-based group. So quite a bit of experience in education, and she is our panelist to discuss those who have an interest in medical education as a career goal. So I'll hand it over to you, Dr. Kent.
Thank you so much. Yes, it's a morning time for me, but I think evening for everybody else mostly. Okay, so I'm just going to talk briefly about being a surgical educator. And some of you may remember this scene and some of you may be too young for it, but this is, when you think about being an educator, I think we all want to be captivating and effective, as was this teacher from Dead Poet Society. Not perfect, but effective. So I think surgery and education are really very closely intertwined. And for many of us, we may have been attracted to surgery because in part of the people that we work with, our residents, our chief residents, our faculty, and that was certainly the case for myself. In fact, I listed here my own path just to give an idea, but there's many varieties here that you can take if you're interested in more formally incorporating education into your career path. I would just say fundamentally, remember that you're a surgeon. That is our core, and to stay true to yourself. We're all a little different. We bring something different to the table, but we have to remember who we are in this whole process of moving forward through our careers in general. So actually, I wrote here first line, I wanted to be like my admin chief, but I would say that it started before that I wanted to be really an educator. And in fact, it goes back to why I went into surgery in general, which is because I really wanted to be like my chief resident when I was a student. So we are all always role models, as I think everybody on this call knows. So I took the opportunities during residency to learn how to participate in the administration of the program to the extent that it was possible, which has changed a little bit now for current residents or fellows. But then took that on, so I knew a little bit what the program director was working on and how that role functioned. So I was a little bit familiar, but I would say really only the tip of the iceberg. So when I became a faculty, I started volunteering for many teaching activities. As a junior faculty member, I would encourage you to do this as well. And I think even if you're not interested in taking on potentially a major role in surgical education, I think it's a really good way to be involved in your division or department, and also to see what other people are doing and learning, and how you can be a more effective teacher. So I did that for sure. And I also think it's important to try to get to know and support your trainees, whatever level of trainee you're working with. And I think the same holds true when you are senior faculty working with more junior faculty. I first took on a student leadership role, which is the case for many people starting out. For some reason, these seem to be more available to earlier stage faculty. I would say they are certainly no less important, but this might be because there's a little less regulation around these opportunities. And so I did take an assistant clerkship director role, which was sort of handed to me as was done then. You'll do this extra work and just figure it out. I enjoyed working with the students. I learned a lot more about the medical school environment and also the student environment in my institution. I think that may be a little unique, depending on, certainly amongst academic centers. Harvard is unique because it's one school and multiple institutions, but just to note that then is a different model as well for people who are working in hybrid or community settings, and also people working outside the US and Canada. So when the opening came for program director, I actually would have probably not applied for it because I considered myself too junior or not ready, but was encouraged to apply. And obviously I got that role, and I've stuck with that and have been program director since then. That is a big commitment. And I think there are many ways to be involved in education that may not necessarily have to be general surgery residency program director. I know many of you may be working or hoping to work in places that have fellowships as well. So currently managing the ACGME requirements for programs those are the same regardless of the level, whether it's resident or fellow, but it's obviously the magnitude is typically, like the number of people you're managing is typically greater for general surgery residency. One thing to look into or to consider is becoming a vice chair role. So we have vice chair for education. This is called different things in different places. Sometimes it's assistant chair, or also I've heard associate chair, but essentially taking a higher level leadership role in the education of the trainees at every level. So I have direct oversight for the general surgery residency, but have kind of a overarching oversight working actually with the program directors of the other programs like ENT, for example, urology, and also for the fellowships and for the student programs again. So this is something that is a very poorly defined role. And in fact, there's now an effort through ASE to work on defining what this role could look like in different settings. And so I'd just say that this has been an opportunity to develop a role in a way that I thought might be effective, and to get input and, to go with things as they change. And I would say that those opportunities will come to you as well. And those are things you can consider and are a nice way to take on new opportunities. And then, as was already mentioned, I'm involved with the a grant, and which is why I'm in Vietnam right now, working on restructuring education here. So I'll come back to that in a minute. So again, there are very many ways to be involved in education. I would say keep focusing on being an exceptional surgeon and an exceptional clinical teacher. Also, it's an opportunity to be a mentor and advisor or a sponsor as you move forward. And fundamentally, we have to do our core, our core work. If you're interested in getting into or figuring out what more of an educational role might look like, I would suggest looking for opportunities to take ownership of something specific within your department, which could be, for example, the robotic curriculum. It could be a small piece that you can develop and or own. It could be simulation, it could be taking on, we have our clerkship students have a student tutorial, which is, you commit to meet with them an hour weekly during the entirety of their 12-week clerkship. So something like that. There are many times we are very much looking for individuals to take on those roles because it is a little more of a commitment, a repeated commitment. And it's a good way to see if that fits for you and how you'd like to develop yourself. Keep your eyes open for leadership opportunities as they come up in your division or department. That often at any level, student, resident, or fellow for education will start as the associate or assistant role, which is a good way, again, to get into a position, see what it's about, and learn what your opportunities are. You may find one fits better than the other. For example, I enjoyed the clerkship role, but I actually am I'm definitely a more GME person, and I would like working with residents more so than with students, and obviously both are valuable as are working with fellows, but I think it's important to take the time to see where you think you fit best. There will be roles to engage with in your institution as well, like serving as a liaison between the medical school and the hospital or the institution, working with the central GME organization. So for us, our designated institutional official, who is our institution's liaison with the ACGME, has a number of people that work under her, like associate DIOs, and those are other roles that you could explore. We have someone who does that role for wellness across all types of trainees, so not just surgical ones. So I would say this is what's interesting about our GME centrally is that they've been pretty open to developing roles as the need has arisen. So we have someone who works in GME for wellness, for QI. So these are ways you can combine your interests and contribute to the educational mission and see if you would like to take a leadership role. There's always opportunities to volunteer with working with the regulatory bodies like ACGME, the ABS, or the Fellowship Council, for example, which sometimes take a little bit longer to do formally, but there may be opportunities to do like standard setting exercises, which I did as a more junior faculty, which was interesting. I am working in education research. I'm happy to talk with people who are interested in developing a sort of a profile of or engage in education research. These are often collaborative efforts, which can be quite rewarding and also a nice way to work with others in the education community. And then I am working on this Vietnam project, which is working with obviously Vietnamese educators at their request to work on restructuring their graduate medical education. And I know that there are many efforts like that that you could collaborate with as well. I think I listed all these out because I think, obviously everyone on the call has different needs and is in a different setting, but there are certainly education opportunities in every setting that are available. It just may be tailored to what's specific to your own context. I think I went through all of this. I didn't mention about getting involved with your society. So AHPBA, for example, has education and training committee. There's obviously, if you're in a program leadership role, there's program director committee, many opportunities to engage. And I would just don't be shy about volunteering for those opportunities when they arise. Remember, fundamentally, be a great teacher. This is an old slide that I just like. And as was already mentioned by Dr. Rose, we're always kind of role modeling, and we have our own role models and mentors. And these are some of mine, people that inspired me to go into education, to be an educator, and to do my clinical work with an education focus. I know that you'll know many of these people. And then lastly, seek out some mentors. Here we are here to help, and as well as other people I know. My mentors have been mostly surgeons, but not all surgical educators. And it's important to keep in touch. And lastly, remember to be yourself. And I will stop with that and take any questions.
Thank you so much, Dr. Kent. That was great, especially because we oftentimes hear about research. Of course, we hear about clinical leadership, but not a lot about education. But it's so important, and it's something that a lot of us interact with, whether it's medical students, residents, fellows. And so having that experience in education leadership is very timely, especially because we're starting to have quite a bit of focus on that. Did anyone have any questions in the chat, or even any of our panelists, for Dr. Kent on mentoring in medical education? If not, I always got questions, so I will bring one.
I was going to ask Dr. Kent, were most of your mentors from outside of your facility, or did you seek mentors that had done education within your own university?
I think so. That's a great point. I would say I think it's important to have mentors who are in a lot of different ways. So mentors who are kind of more near and more far. And I can just give the example everybody probably knows, like that's in age, I guess I would say, if I'm allowed, which would be for me, have been Dr. Vollmer and Dr. Callery. Like one's, Dr. Vollmer's a little bit closer to my age, and he added that was mentorship in terms of career development, and really I would just say supported both of them had education roles, but supported my own development to identify my interests, which was a little more education focused than they had been. And then I think also it's important to have geographically near and far mentors. Certainly, I've never worked in the same place as Rebecca Minter, but she's been a fantastic mentor for me in general, but specifically relating to developing a surgical education focus. And so I think particularly as we grow, and we have this great opportunity through AHPBA, which is how I got to know her specifically, to have mentorship and connections across institutions. And that is a really valuable thing to take advantage of, so that we can grow in ways that we may not envision if we're only considering what happens at our own home.
We do have a question in the chat for Dr. Kent. Do you know of any online education career opportunities? That's from Emilio Tanina.
Sure. For courses in generally courses in medical education, there are a variety of online courses. I know that Harvard Medical School does one. I think there are also actually formal graduate like education degrees. SIU has had one, although I haven't checked on it recently. That I am sure those are not negligible in cost. But there are often there are webinars about developing educational opportunities. I know that are hosted by outside of AHPBA as well, like through the American College of Surgeons, as well through ASE, APDS, and other career development ones through like the AAS as well. I don't know if that answers your question or you're looking for something specifically, but there are definitely online opportunities available.
Thank you so much. And of course, for all the participants, feel free to include questions in the chat and we'll get to them after each speaker. I'll move on to the next speaker, Dr. Hussein Osman. So you can go ahead and share your slides if you like. So Dr. Osman is a hepatobiliary and general surgeon. He's in the category of a non-academic or private practice, but I must say, knowing his practice, there are some elements, quite a few elements of traditional academic environment there, whether that be research, publishing, education, medical students, residents, he's got it all, but just outside of a true university setting. He graduated from medical school at the University of Khartoum in Sudan and did his general surgery training at Western Reserve Care System in Akron General Medical Center. He then did fellowship at Methodist Dallas Medical Center. And now he's currently in practice at Methodist Richardson Medical Center in Dallas, Fort Worth area. So he does have skills, obviously, in hepatobiliary surgery, but also has a practice in diseases of the esophagus as well as general abdominal surgery. And he's also very active in the American College of Surgeons North Texas chapter. And so I will hand it over to him to give his perspective on non-academic first career / private practice. Thank you so much, Dr. Osmond, for being here.
Thank you, Kim, and great talk so far. Good evening, everybody. So I was asked to speak about non-academic first career or private practice. And so what I'm going to do, I'm going to talk about my personal experience. And from that, I'm going to try to share with you guys lessons that I've learned, and then finish with some advices. There is nothing that you haven't heard before, nothing that you do not know. So hopefully this talk is going to be just thought-provoking more than actually adding new information. So my story, as you heard, I studied medicine in Faculty of Medicine, University of Khartoum in Sudan, completed my residency training in Ohio, and did my fellowship with Dr. Raja in Methodist Dallas, which was a combined HPP and FORGUT fellowship. My story, then after the fellowship, I was lucky to join my mentor, Dr. Raja. As you can see in the picture, in the past 10 years, Dr. Raja has not changed, and I look different. So our practice is private kind of / hybrid practice in the Dallas Metroplex area. We started in Methodist Dallas, where I did my fellowship, finished our fellowship. 3 or 4 years later, then we moved our practice to north suburb Dallas, which is Methodist Richardson, where we currently at. The practice has 3 surgeons, Dr. George and myself, and we are currently joined by Dr. Buell. We have HPP fellowship, and we have advanced GI or complex GI fellowship. We have rotating surgical resident and rotating medical students. Our practice is what Dr. Jarraj likes to describe as a 3-legged stool: clinical component, educational component, and research. And if you look at that, if you think about it, this is really describe your impact as a surgeon and even as a person. You either impact individual around you, you can impact your community, or you can impact generations. And between the clinical arm, the educational arm, and the research, you can see an impact, individual level, community level, and generational impact. Private practice at the end of the day is business. So the way I looked at things, my story is that when I finished my training, I quickly realized that our personality is changed in our 20s and early 30s. For us physicians, this is where we focus on our career and as a lot of time ignore some of our non-medical kind of part of our personality. So finishing your training and starting your career is a good chance to look inward and set goals, set new goals for yourself. And you have to ask yourself, what would make me happy and satisfied? That is very important before you start your journey and your practice. For me, as everybody, the majority of us, it was a combination of career goals, family, social life, and personal interest. My goals personally, I wanted to have that balance between my career, my personal life, and I wanted to kind of develop have some personal growth opportunity. I love to be clinically busy. I love to be in the operating room most of the time. And as you can see, I'm still in scrubs and still in the hospital. The fellowship was very important to me. The fellowship gave me a sense of education, and having fellow fulfilled some areas that I thought were important to me and sense of achievement as well. Career advancement as well. I wanted to have a chance to advance my career in multiple level. And just like any private practice, it is about volume. Volume will give you the opportunity to advance your career and do other stuff. If you're not clinically busy in private practice, you're not going to be able to achieve other goals. I'm sure you've heard this before. To build the practice, you need the 3 A's: to be able, to be available, to be affable. And the lesson that I've learned very quickly that the 3 A's are must, but not enough. So you have to ask yourself when you're private practice, because if you or when you are in private practice, patient will likely be referred to you. Well, if you're in a big center with a name, patient will be referred to that center. So you ask yourself, why me? So your aim and goal in private practice to be competitive is to be the best option for the patient and for the referring physician. So either you have to deliver a quality of care that is superior to other, or you deliver something that is unique in your area, a service line that is not provided, and you want to be easily accessible to referring physician and to your patient. And you want to maintain an open line of communication. Another thing that I found very helpful for me was the generation aspect of referral. You'll find that when you finish your training and you're young, that it'll be easy to communicate with gastroenterologists, medical oncologists that are your age. Some of them will feel comfortable talking to people their age. Maybe they're not intimidated by your senior partner that are older and more experienced than them. And a lot of time you guys grow together, which it may not be easy at the beginning because they are also trying to develop and build their career. But as time goes by, you'll see that actually they develop their practice, you develop your practice, and you guys grow together. And for the referring physician to send the patient to you, either they need you to provide a service that is not provided somewhere else, so they need you for their patient. And they want to trust you. We all talk about patient ownership and how as surgeon, we see ourselves as the cream of patient ownership. But I can tell you that primary care physician, they own their patient. When they send their patient to you, they want to know what happened to their patient, and they want to make sure that they're well taken care of. So trust to them is very important, and they want to be comfortable with you. You also want to create growth opportunities, because being passive is unlikely going to help. So, and you have to find what works best for you. Some of those things worked for me. Some of them actually did not. There is the traditional marketing. You have a pamphlet, you go out, you shake hands, kiss babies, and introduce yourself. Worked for a lot of people, did not really work for me. You also need to identify new referral sources, whether new practices, other location nearby that you want to get their business. You want to develop a service line, especially if you join a practice that does HPP. You want to find your place in that practice. What service you're going to be providing differently? What is going to be your line? What's going to be your niche? Are you going to adopt a new technology that is currently not provided, and you're going to use that to market yourself? Educational activity and social event were very helpful, and where you really introduce yourself to the community and to referring physician. Social media is something that I do not do. I'm not good at, but it worked for other people. So lesson that I've learned from my experience so far, that I am not perfect and you're not perfect. So emphasize your strength. You have to look inward, figure out what are your strengths. Are you a good in networking? Are you a good clinician? Find your strength and emphasize that. Let people around you see your strength, and at the same time, work on your weakness. We all have some. Lesson, a very important lesson for you who are going to graduate in a few months. You are not your mentor. Whatever you see that happening to your mentor, the patient that he's getting, the treatment that your mentor is getting, that treatment is earned. It is not given. It is okay to adopt what your mentor is doing, but you cannot imitate. Adopting meaning that you understand what they're doing and why they're doing it, and then you adopt that to your style. If you only copy paste, you're not going to be able to get out of trouble. So adopt, but do not imitate. You heard this. Be yourself. Be true to yourself. Find your unique place in your group, in your hospital, or in the region. Another lesson, take on new challenges, but be safe and methodical. Especially when you start early on, you do not want to be the cowboy who want to do stuff that are difficult or challenging and nobody else is doing, and you want to prove yourself. Take on new challenges, but be safe and do it in a methodical way. take a new responsibility, but do not spread yourself thin. Now I'm going to move to some advices for your first job. When you look for a first job in HPP and private practice HPP, first thing that I would advise is to look for the HPP practice potential. Are you going to be solo, or are you joining a group? Is that group performing HPP or not? If that group is performing, or the hospital, if there's an HPP volume, who is doing that volume? Where is the opportunity for growth? And you want to look at the facility. You want to look at the logistical support, and most importantly, you want to look at the vision of that facility and the leadership and the stability of the leadership, especially if you are going to be tasked with building an HPP practice. You want to make sure that your vision aligned with that leadership, and that leadership is stable. You don't want to join a hospital or a system, and then 6 months later, you find that they have a new president, a new CEO, and now they want to focus on neurosurgery, and you're not important to them, or HPP is not their priority. And the location that is important to you and your family as well. I don't think one of the goals or aim of this talk is to discuss a contract, but in private practice, there are different type of contract, different type of private practice. There's a pure private practice where you are responsible for the overhead and your malpractice and everything. It's a true, pure, all private practice. There is a professional service agreement where you align yourself with a system or a hospital, and that will take the overhead from you, but you're still responsible for other stuff like your health insurance or malpractice, depending on that type of contract, and your salary is RVU based. Or there is the pure hospital employee model. So also look at your contract and figure out what your contract is. A controversial opinion, that's why I did not call it advice, I would call it a controversial opinion. I would pick growth potential over starting salary. I know everybody likes to look at the starting salary. Is it acceptable? Is it, oh, somebody else is getting higher salary? Starting salary is cool, but if there's no growth potential, once you move on from the guaranteed salary, you may run into some challenges and difficulty. So, but if you look at the growth potential, that will allow you to be productive down the line. And even if your starting salary is slightly below average, that growth potential will allow you to get there, or what you want to get, or what your goals are. Another thing that I want to talk about is, what if your first job was not what you expected? Now what? I would say, what I've learned from, and I stayed in the same practice since I finished fellowship, but what I've learned from my own experience and other people's experience is that there is a reward for sticking around and outlasting people. But you also have to define your red lines. There are certain things that you have to say, enough, this experience has not worked and I need to move on. Red lines that you have to identify early on. And I would give an example, for example, an ethical red line. If you find that you're being asked to do something that does not align with your ethical conduct or codes, then that would be a reason to leave. But I would advise not to leave or abandon your job at the first challenge. Another important thing is that even if things did not go well in your first job, this is not a failure. Evaluate what happened. Do not blame external factor for that. Try to look inward, evaluate why that job did not work or that experience did not work, and try to identify what are you going to do different in your new job so you can improve and you do not repeat some of the mistakes again. And my brotherly advice to you, keep your eye on the destination and enjoy the journey. Thank you very much.
Awesome. Thank you, Dr. Osman. That was very good. As a another surgeon who's in community or non, traditional academic setting, a lot of that really resonated with me. Feel free to put any questions you may have in the chat. Dr. Jiraja asks, do you have any advice about doing research in this environment?
Yes. So in private practice, you will find clinical outcome research kind of fit in that model. Also find try to be practical. Try to do research in an area that you're interested in question that you have that you want answer for. Being in a private practice allow you to be busy, and as I said earlier, volume fix everything. If you have the volume, you can actually do good clinical outcome research. Having the volume will give you the clinical experience that to ask question, I've noticed this, or I've noticed that. I wonder if we do this differently. And that will allow you to do research that are applicable to you. And actually, they are rewarding research because the outcome from that research can be applied pretty much very quickly and immediately.
Looks like there's another question. How do you justify bringing new technology to a location without having the referral base volume yet?
And that's why you have to align yourself with a system or a hospital that share your vision. Meaning that if you are a new hospital or a new system and they would like to build an HPP practice, and HPP practice will generate a lot of RVU and for the hospital. So if that is their goal and their plan, understanding that when you build that volume, then that volume will pay for that new technology. But that will require commitment from that institution. It's also going to require commitment from you as well. So I cannot answer that question generally. It comes down again to the align yourself with the right group or the right institution or system and be committed to that plan, and you want the institution to be committed to it.
Thank you, Dr. Osman. I have a question. I work in Hartford Hospital in Hartford, Connecticut. We're affiliated with the University of Connecticut, but we are also not employed by them directly. So we're in essence also a private practice. How do you deal with residents and resident autonomy in a private practice setting where outcomes are very important, but also speed and efficiency and trying to do many cases in one day, as opposed to taking the time to let them go through the case?
I'm going to answer that from a fellow's perspective because we have a fellowship. It's still a bit kind of difficult with resident because depending on the year of the resident. The way I look at autonomy is start from at the beginning, the resident or the trainee, they have to kind of understand what we try to do or how we do things. And I progress from an active or a co-surgeon to an active assistant to passive assistant. Having the fellowship will allow us 12 months to do that. But when you have a rotating resident per month, or they're not with you all the time, you have to identify what part of the case that is going to be a good learning opportunity for them. For example, if I have a PGY2 or PGY3 for Whipple procedure, a gastrojejunostomy is a good component of the case that I can give them some autonomy in that. PGY4, a hepatojejunostomy may be a little bit more appropriate. If I have a PGY4 or PGY5 who have rotated with us before and they went through the learning curve of things, then I may allow them to do the pancreatic jejunostomy. But I think based on our experience here, if things are done right, having trainee does not really slow you down. And I think that's proven in other papers and articles that having training does not slow you down and it does not affect the outcome negatively. And I think if they feel like, and when we talk about outcome, not only the OR, we talk about imagine patient post-operatively in the floor. And I think if they feel that they are part of the team, and as you said, in private practice, we are there all the time and available for our patient. So we'll give them room to come up to evaluate and come with a plan, but we're always there to either agree, disagree, or adjust the plan. Hopefully that answered your question.
All right, thank you very much, Dr. Osmond. We will move on to our next speaker. Dr. Kimberly Burtons has completed her medical school and general surgery residency at the University of Western Ontario. She then went to complete a fellowship in hepatobiliary surgery at Virginia Mason Medical Center in Seattle, Washington. In addition, Dr. Burtons has completed a master's in public health with a focus in quantitative methods at the Harvard School of Public Health. Her research interests include the interface between socio-demographic factors and access to surgical care. She's going to speak to us about the mentoring experience in Canada. Dr. Burtons, you have the floor.
Perfect. Okay. Yeah, so I'll talk to you a little bit about mentorship in Canada. I will make a caveat that Canada is a pretty big country, and I suspect that some of the experience would vary across the country. So I don't have any disclosures with regards to the talk, but it is heavily influenced by my own personal experiences, which will be unique. So Morgan already sort of talked about this, but basically my first staff job here has been in Ottawa, and I've been here for 8 years now. One thing that you will note in Canada that is quite different from the US is it's not that common to move institutions. So we often stay at 1 or 2 institutions for an entire career. So I suspect that my experience with mentorship will be more guided by the fact that I have a very unique practice model than the fact that I'm in Canada. So I just want to explain my practice model a little bit because it does really change what my experience was when I was looking for mentors. So I have a true group practice model. And what that means is we have centralized referral. So people in our region just refer to AHPB, not to one of our names, or if they do refer to one of our names, it still goes into the group pool. We have one queue for patients for both clinic and surgery booking, and they're booked with the next available surgeon. We have shared care of all of our patients. So surgery could be booked by surgeon A, for example, performed by surgeon B, and the post-op care could be taken on by surgeon C. So these are my 4 partners, or 3 partners, and I guess I'm the 4th. So we have Dr. Bala, Dr. Martel, Dr. Abu Khalil, and myself. And then part of our experience with this is that we often double scrub cases, which again is different in Canada as it is in the US. And some of that has to do with the way our funding is. So we're not sort of ever chasing RVUs. We're paid fee for service by the government, and assisting fees also are paid. So early on in our career, it's not uncommon that we would have colleagues scrubbing with us. So if anyone's a little bit more interested, I don't want to make this a talk about group or shared practice, but if anybody's more interested about that, one of my partners actually published our experience with respect to complex hepatobiliary surgery recently in the Annals of Surgery, and it sort of details exactly how our practice works. So I kind of divided this into different topics. So clinical mentorship in Canada. So one thing just to point out that is a little bit different in Canada than in the US and potentially in South or Central America is that in Canada, HPB is really an academic specialty. So we don't have the same private practice model. We have a public care system. We do have community hospitals, which are smaller institutions, and they are often affiliated with an academic center. But hepatobiliary surgery is generally done at the bigger centers. There are a few exceptions to this, namely in British Columbia, it's perhaps a little bit differently run. But for example, in the province that I am, which is the province of Ontario, the government has set 10 centers as HPB centers of excellence, and those are the only centers that are allowed to do HPB surgery. And what that means is you really are never practicing HPB alone. And in fact, that's one of the criteria for credentialing in Ontario is that you have to have more than one surgeon that's performing that operation. So in general, you're going to have partners that do very similar work that you do working at your institution. For research mentorship, my suggestion for that would be to find collaborators within your specialty, but also cross specialties. So look for people with similar research interests to you, and think about the spheres of medicine that are around surgery as well. So we have lots of collaboration with our anesthesia colleagues, perioperative medicine, oncologists. In Canada, in general, HPB is a pretty small community. And so because of that, there's lots of potential for multi-institutional trials. We hold a meeting every year at the Canadian Association of General Surgery meeting called the AHPBA Concept Meeting, and trainees are welcome to come to that as well. And at that meeting, researchers will present ideas for trials, or they may give updates on trials that have already started. We have a centralized group called the Canadian Clinical Trials Group that runs all oncology trials through Canada as well. So my advice for somebody starting out a career in Canada that's looking at doing research is to reach out to some of the people in the community of HPB that are already doing a lot of research, make it known that you'd be interested in being a site PI for trials, and those invitations will come. And I find that when you're trying to work and learn how to do clinical trials, one of the best ways to get experience with that is actually being a site PI and learning how those trials are running. You could also become a member of the CCTG as well, which could help you to be contacted about oncology trials. And then for personal mentorship, I think these are often people that have an interest in your leadership or career goals. And these could be people that are within or outside of your institution. So I've got a picture there of myself quite heavily pregnant. I think I had my son a few days after that, with Fatty Bala, who's been a huge personal mentor to me throughout my career. And then the other gentleman is Richard Mimo, who I actually took over his practice when I started, and he continues to mentor me 8 years later. And much of his advice is more about gardening these days, but he's been a big inspiration for me as well. Seek out those that have similar paths to what you're hoping to achieve. So, if you're looking to do a lot of research, seek out people that are known for doing that. If you're looking to do leadership roles, so division head, department head, in Canada, it's quite common to be involved with provincial administration. Seek out the people that already are doing that work and make your interests known, and you'd be surprised at how many invitations come from that. I was very lucky within the career of HPB. Not only did I have a lot of mentorship here in Ottawa, but also I had especially some female HPB surgeons from Toronto, Dr. Natalie Coburn and Julie Halle, who reached out and got me involved in projects and with provincial leadership as well, which has been very rewarding. And then from a standpoint of personal growth, I think that what's really important is to be open to criticism. So, when you're first starting off, it's a stressful time. It's hard to really understand exactly how to become part of a culture that you maybe aren't familiar with if you didn't train in that place. It's hard to learn how to communicate effectively in the OR when you're going from being the trainee to the staff. And so be open to criticism or suggestions from your mentor about how you can do better. And as long as you're willing to hear that, I guarantee you'll grow from those things. And then Morgan asked me to also speak about how can you keep mentors engaged. So I would say pick mentors that stand to benefit from your success. So, people that actually directly stand to benefit. So if they see you do well in research, that there's possibilities for research collaboration down the road. If these are people that are helping to mentor you for leadership positions, that you may be actually in a role of leadership of divisions or departments that they're part of. If they're giving you clinical mentorship, be available for reciprocal clinical coverage, or be available to also help them when they are asking for help as well. And then also, many people are indirectly benefited from your success. So the sense of well-being or altruism of seeing someone succeed that you've invested time and effort into. I would say keep regular touch points with your mentors, and all of your mentors may not be people that you're seeing or working with every day. So make a point to reach out to these people, let them know how they're doing. If they brought something to your attention, like a job posting or a leadership position, make sure you let them know if you did apply and how that went. Let them share in both your successes and your challenges. And that's all I have. I could take any questions if there are any.
That's great. Thank you very much. I had one quick question. What was a good resource for you when you were looking for mentors, especially like outside of your facility, to find people who has, shared, as you said, shared the same career goals and interests as you did?
Yeah, so like I was mentioning, HPB in Canada is a pretty small community, so we all essentially know each other to some degree or another. Being part of groups like the AHPBA or the Canadian Association of Hepatobiliary Surgeons is very helpful, because you'll actually meet people. Going to meetings is important too, making sure you get outside of your city and that you're having opportunities to meet people. And I found that a lot of those relationships just sort of naturally took off from conversations, at meetings, and knowing what my interests were, and that, I always said yes early on to things that I had any interest in whatsoever, and always made sure that I did a really good job at doing them, and was someone that if I told you I'd have something done by a certain deadline, I would. And I found that by doing that, more and more offers came my way, because I kind of got a reputation as somebody that would get the job done.
Great. Do we have any other questions? Dr. Burtons? All right, I'll hand it over to Dr. Siriano then.
All right, thank you very much. And I have the pleasure of introducing our last speaker for the night. Dr. Martin Dib is currently the director of the Living Donor Liver Program at Beth Israel Deaconess in Boston. He is originally from Chile. He went to the University of Chile for medical school, from which he graduated, and then came to Harvard to do a research fellowship, and subsequently finished his residency there. After spending some time in Boston and completing his general surgery residency, he went on to complete the fellowship at the University of Toronto in HPB and transplant training. After that, he went to the University of Wisconsin and spent a couple of years there before going back to Chile and becoming the chief of transplant surgery, where he had been for approximately 5 years, establishing the Living Donor Liver Transplant Program there, and was very successful. He was also very instrumental in establishing the HPB Fellowship Program in Latin America, which basically takes Latin American trainees and takes them through different sites in Mexico, Chile, and Brazil. So it's my pleasure to introduce him. Without any further ado, Dr. Dib.
Thank you, Oscar, and thank you so much for the invitation. I'm gonna give a talk that sure is perspectives unique to Latin America, but I'll try to make it also you can extrapolate for other international trainees or other countries, or any trainee or any junior staff that is going through a path that may not be in only one place. So I recently moved. This is as of this week. I just moved back to the place where I did my residency. So it's a very special move, and I'm going to tell you a little bit about it. So first of all, in terms of disclosures, I owe my career to my mentors. So this is very special for me to be giving this talk. There are multiple paths to the same destination. So it's not only one way of doing things. This presentation includes part of my career, so it's subjective. And the aims are to highlight opportunities and struggles coming from Latin America or from other parts of the world, help future Latin American HPV surgeons to choose their path. And I'll show you a little bit of this interesting Latin American HPV fellowship, which is in 3 countries, 8 months at a time, because I think is a model that may be something that we can do in other parts of the world. So I think so. This is my path. Oscar described it, and I really thank him for it. I did my med school in Chile, where I grew up, and I had this amazing opportunity to come to Harvard as a med student, and then they asked me to do a research fellowship and my residency there in Boston. And then after that, my career completely changed. After that residency, I was able to get a very good fellowship in HPV and transplant in Toronto. And then I was hired to go to Wisconsin to develop a live donor program. And then they called me, and this decision was interesting because they called me back from my home country, which is something I always wanted to do, to make an impact back home. And they were having like a 35% mortality on the wait list, and they needed some complex HPV program. So I decided to leave a very good job in the US to go to my home country. And I did a 5-year period that was extremely special for me because I was able to really build a team to do something that wasn't really being done there. And recently, as I mentioned this week, I moved back to Boston for an opportunity to make an impact in a different way. So I'll show you a little bit of that. I think every decision starts with an opportunity. I had an opportunity as a med student to come to Harvard to do a clerkship. And that really opened my eyes to different ways of doing things. I saw a general surgery program in the US and how it really functions here, and that really opened my eyes, and I wanted to do my training the best I could. And so when I made the decision, I was deciding what to prioritize, to get the best training possible, or try to get a good family work balance, or maybe have a financial stability. Many of the residencies or fellowships in Latin America are not paid, so it's very tricky. But they have less years, so it kind of works still. To acquire the best context for the future, to finish training as soon as possible, or to get the most number of cases. So in that regard, like maybe we want to do all of this, but you do need to prioritize when you're making that decision. So when you compare Latin American track versus US, it's kind of similar. Most Latin American med schools are 7 years, and then most general surgery residencies are not 5 years. So they're like 3 years, and then you do some sort of fellowship that will become like 5 years of training, and then you're a staff surgeon. But many of the people that really do become leaders in Latin America try to do some sort of training outside, and many of those go to the US. So one way of doing it is to do this, which is probably the most common, to go like from, I'm sorry, this is actually not the most common one. So go from general surgery residency of 3 years to a fellowship in the US is actually very difficult to do. So many people will not be very competitive. But the most common is actually to do like subspecialty training in Latin America, and then do a fellowship, a formal fellowship, which is high volume in the US, and then go back to their country and make an impact back home. Then this route, which is, general surgery residency, then do a subspecialty training in Latin America, and then go to US to do a high volume training in fellowship and stay as a staff. It's actually very difficult. There's some visa issues. You're not board certified, but there's some people, very unique people, that have done it, and I think that can be done. But I would say it's almost impossible. So the track that I did, which was going from med school to general surgery residency from like being, very young, it's unusual. But it has some benefits, and some people have done it. And I think that was difficult to do. I had to do research for 2 years and really prove myself. But it has the advantage of being board certified, and that residency really helped me get to a very competitive fellowship. And then I was a staff surgeon, and then I went back. So it's kind of the long road. So, but all roads lead to Rome, and I think the most important is to understand what's Rome for you. Where do you want to be in 5 years, 10 years, and what do you want to accomplish? I think is very important. So my objective, I decided to apply for the best possible training. And so I did 2 years of research, and I think that's a very good advice for people that are applying to do research, to get people to know you, to go to the podium in conferences. And I think that really enriches your CV and your ability to discuss the topics that you're an expert during your interviews, even for job interviews, right? Then I did the USMLEs. I had to validate my degree. The visa is also a huge step, and being able to practice and the amount of years you're gonna be in the US is something that many times you don't know, but then you realize you need to be an expert on visas. And then I applied to a national match, and I applied to 30 programs, of which I only got 2 interviews, despite having good results in the USMLE. I think it's interesting to realize that coming from from another country, the fact that people need to know you is important, because otherwise it's very difficult to get interviews. They don't want to hire people that are good on paper, and I think having advocates for you, having mentors that could speak for you are very important. So I did my application in residency, and I got a categorical spot, which I'm very, very grateful. And I think during my period, my colleagues, my co-residents, and my co-fellows are probably the people that I learned the most from, and that is an advice that I always give. I feel, your co-residents, your co-fellows are basically friends for life, and they will continue to be. And I actually have a group chat with both, and I think that's one of my most used resource. I went to Wisconsin, which was a great opportunity to be in a transplant and hepatobiliary practice. And as I mentioned, I had this opportunity to, learn in North America, to be able to give back in Latin America, in my home country. And, many people have done this and have not been successful, because it really, really depends on where you land. And I give this credit to the team that really hired me. I think choosing your team when you get your job is the most important thing. If you have a team that will not validate your training, or they're gonna compete with you instead of collaborate, I think that's never gonna work. But my chairman, who hired me in Chile, the first case we did together was basically saying, okay, Martin, just, teach us or tell us how it's done. And that's what you want to get. You want to get a good team that will collaborate and be able to grow with you. We were able to grow a program, a live donor liver transplant program, and a multi-organ transplant institute, and we did 73 live donors, which is maybe not as much for the US, for a US program, but it was huge for Latin America. And we started doing them laparoscopically. We got national records of organ transplants in the country. And now it's a serious program that will continue to grow with or without me. We developed laparoscopic right liver donation, and I just wanted to mention this because I had a mentor that was David Kwan from Cleveland Clinic, and this was a distance mentorship or telementoring that I call. And this was great. This was a very generous surgeon who's very talented and really, helped me develop laparoscopic and minimal invasive donation by going there, but by then like talking to me frequently, and I would watch his videos and I would ask him questions about the instruments. And that is also something you could do. It doesn't need to be, as Dr. Kent was saying, you don't need to really necessarily have a mentor that is with you. It could be somewhere else, and you can still have mentoring even for technical things. So this is the learning curve that we developed in this particular operation, which is live donor liver transplant. And for the donor, we started doing them laparoscopically, and that was like technically was a very rewarding path. Another advice is like is the fact that you don't need to only be in the OR. I think when you go to other countries, especially in Latin America, you realize that many of the growth of programs means that you need to engage stakeholders, you need to change policies, you need to really do outreach and make people and the public understand what you're doing. So we were able to actually change a law of living donation and to allow now for the past 3 years, they started allowing living unrelated donation thanks to all this work that is outside the OR. And I think that's really important. So as I said, I think it's not about the seed only, it's about the fertile soil to be able to have success and the team that you can collaborate with. And that is the major way to make the highest impact in your career. Mark Callery was one of my mentors, and he actually, when he was president of the AHPBA, was able to change the name of the American HPV Association to the Americas, and really include chapters of Latin America, and that really has decreased the gap between Latin and North America. And I think this was a huge change, and I think has inspired us to try to do other things. And among those things is that we created this Latin American HPV Fellowship. That is the first one in Latin America to have AHPBA accreditation, and it's a fellowship program that combined experience between the largest programs in 3 countries. And so they have a 24-month 2-year fellowship, but it's 8 months in each country. And it has been an amazing experience. And I think that maybe we could even do this in the US or in other places of the world, because it really was something that was a product of the educational committee at the AHPBA. And it has been amazing, not only for the fellows, but also for the programs. So Adnan Al-Saidi and Brendan Visser were instrumental in this creation of this fellowship. And this was the first fellows that are now finishing. And they basically gained their AHPBA numbers during the first year. Like the first 8 months, they were almost done with the numbers. It was incredible. So it has been an amazing experience of sharing fellows. We have learned so much from the Mexicans and the Brazilian surgeons just by having a fellow that have rotated with them. And obviously, like it for them, it's not only a surgery experience, but also a life experience of how you do things in a different part of the world. And that has definitely benefited patients. And so it's really a virtual cycle. This is, we have simulation center in Chile that is is extremely good, and I think the plan is to start doing remote simulation within the 3 countries, and this is something that we're working on. So lessons learned, I think, get good mentors, ask for advice, and also keep in touch with them. It's very important to understand where is wrong for you, and where do you want to be at 5, 10 years. Initially in my career, I was always like thinking of 30 years in my mind, and I realized like things change. And I think thinking about the next 5 years is a more realistic thing to do. And I think that's my advice now that I give. Think about what do you want to do in the next 5 years. I think it's good because maybe things change and you want to do different things 5 or 10 years from now. For the first job, especially, the partners and the team is really, really important in order for you to be successful. Get a job where you will make the highest impact. So wherever you think you will have the highest impact, that's going to grow their program, is going to be the best for the patients, but it's also going to be the best for your career. And impact is dynamic. It can change during your career. In my experience, for the 5 years that I was in Chile, it was the place where I think I was gonna make the highest impact. And then, the opportunity that I'm having now to be in this office that was, my mentor's office, and being able to do things globally, I think is probably gonna be the highest impact in the next 10 years. Work on developing a strong system is not only in the OR, but outside the OR as well. This is an advice that one of my mentors gave me. Don't make changes when you start a job for the first 6 months, because nobody likes changes. First, build trust. And once they trust you, you can change it all, but as a group, as a team. And my approach is, family first approach. And I think that goes a long way. If your family is happy, you're going to be happy, and you're going to continue to develop your career. I want to thank my mentors. Dr. Tara Kent is in this call. And Dr. Khalid Khwaja, I have him here because I inherited his office, which is this office, and he passed 4 years ago. And mentorship is important, and I think it's part of life, and you will. I hope to be a mentor to my students as my mentors were to me. Thank you.
Thank you very much. That was excellent. We actually have a question in the chat. It comes from Jorge M. I don't see the full name, but it says, excellent presentation. What is your advice to get an AHPB fellowship position, being an IMG or from a U.S. Community program? Is abdominal transplant surgery, the fellowship, the best option?
Yeah, that's a very important question. So my advice, it depends on really what you want to do, because obviously transplant fellowship is less competitive than HPV fellowship. And for an IMG that is already a surgeon, to get into a transplant fellowship is probably less competitive and easier. But you really want to, get to where you want to go. And many people are not interested in being transplant surgeons. They want to, do surgical oncology or HPV. So I think, there's not one way of doing it. There are many people that do like a transplant fellowship and then do HPV fellowship, or that they do like research fellowship and then get to know people and then really have a competitive CV to get to an HPV fellowship. So all of those paths are, there's no one correct answer to that. But I would say, you know, try to stick to where you really want to be at 5-10 years. If you want to do transplant and HPV, probably, you know, go to a place where you can have hybrid training. It's probably the best way. But if you don't want to do transplant and you just gonna want to do HPV, I think it's probably better to develop relationships, know people that will advocate for you. You know, having the contacts that I've done, I've been able to help and recommend people that have gone from Chile or from Latin America to very competitive places in the US and Canada. And so I think you know, when you find good mentors that know people and could advocate for you, I think is very important.
Well, thank you everyone for your questions. I guess let's make sure there aren't any last minute questions. I think we're right at time, and I'll let Dr. Bonds close us out there. Yeah, after we say hello to the little one.
Yeah, sneaking on there. I just wanted to say thank you, everybody, especially our panelists. Those were excellent talks. I really learned a lot. And I hope to see everybody on this call, including the panelists, at our Meet a Mentor session at the AHPBA meeting in Miami, which I believe is Friday, April 7th. Jill or Margie, please correct me if that's incorrect. But there's no registration or anything like that. We want you to be able to come and meet people who share your interests and give you some insights into help you on your careers. So thank you, everybody. This was a really awesome session. I hope everybody has a great evening.
Thank you.
Thanks, everyone.
Thank you.
Thank you.
Thank you.
Everybody, good night.